Hi, folks. This is John Adamson, the Rehab Documentation Guru, and I am reporting to you live. This is the first time I'm trying a live chat video. Not sure if anybody's watching on a Sunday, but Medicare is alive and well and denying therapeutic exercise. I am reporting to you. I feel like I'm a reporter. I am actually live in Ismail, Ukraine, where we continue our adoption journey. But what I'm going to be talking about today is the fact that this past week, I've been writing a lot of appeal letters related to therapeutic exercise, mainly for Part B services. So we are seeing a lot of denials related to therapeutic exercise prescription. And so I'm just going to talk briefly about that. If I get anybody that comes in while I'm doing this live, great. If not, then I'll be just talking for future people that are watching this. And I'm not even sure how I stopped alive on YouTube, but I am planning to do this in the future, but I'll make sure that it's scheduled and that those that are interested might have some heads up to be on a live chat on YouTube. But anyway, let me tell you a little bit about what's going on with therapeutic exercise. So Medicare is denying it quite extensively. And here's some of the things that we're seeing related to Therex and perhaps why they're denying it. When therapeutic exercise is prescribed, generally it's going to be an expectation that there's a good rationale for it. And so the first thing that Medicare is going to be looking for is a diagnosis that's related to a disease that would cause deficiencies in one of four areas. And some of you have heard me talk about Therex in the past. And so I'm just going to reiterate what Therex covers. So does that disease cause problems with strength, range of motion, endurance, or flexibility? So one of those things needs to be occurring if you're going to bill for Therex. So the first thing you got to look at is, are the diagnoses that you have in your claim possibly relatable to those issues? And then the second thing you got to look at is, can you relate those diagnoses in your analysis statement, your reason for referral, whatever you might call it, to the findings in your evaluation, so that it's clear that your findings support that diagnosis, but then in turn support therapeutic exercise. So a lot of claim denials we have to address are when the diagnosis doesn't necessarily correlate with the need for Therex. One of the things that we see in the long-term care setting is a lot of treatment of patients with psychological disorders. And psych disorders, here guys, I'm going to set this down so it won't be, well, maybe that won't work. Here, let's try this. No, that's not going to work. So anyway, a lot of these psych diagnoses do not necessarily cause a problem with weakness, flexibility, range of motion, or endurance. And so one of the things we've got to make sure is that we can correlate that problem. So for example, you had a patient that went in the hospital for a psych diagnosis for a 7-day stint. They had their medicines adjusted for their psych diagnosis. And prior level of function, excuse me, they were very high level, maybe very independent in mobility and ADLs, but they were maybe in a setting where they had to have supervision because of their psych history and inability to make safe decisions for themselves. They go in the hospital for 7 days. That's likely going to impact them from a flexibility, endurance, range of motion, strength perspective. But, excuse me, one of the things that Medicare says is that they do expect generally, I'm just paraphrasing here, that a spontaneous recovery of those issues will occur when the patient resumes their normal activity. And so skilled therapy is not necessary in those cases, is their perspective. So one of the things you've got to do is you've got to do really thorough assessment of these patients and get to the nitty gritty. What keeps that patient from being fully independent safely and effectively? Because if a patient with a psych diagnosis is only requiring supervision by the time they get to you or contact guard, Medicare is going to say, well, if they're only contact guard supervision, then they'll just work with nursing and everything will be copacetic, or they can work with a loved one and they'll be fine as they recover their normal activity of daily living. But if you do a really good job of nitpicking the problems, and especially when we're talking about Therex in one of those four areas I mentioned, then you can help justify at least some of the skill that you're doing with the patient. It is safe to say, though, that how can I become a great doctor? I just got somebody in the live chat. How can I become a great doctor? I'm not sure. If you want to clarify your question, I'd be happy to. Of course, we're talking about physical and occupational therapy primarily here, but I'll be happy to answer that question if I've got some more specificity to it. But anyway, what I was going to say related to psych patients is that generally, though, if they are psychiatric and they have a little bit of weakness, a little bit of endurance issues, a little loss in range, then generally it's going to be expected to be a very short length of stay. You're looking at limited duration. You're probably looking at not much intensity because with psych diagnosis patients, especially if they're requiring institutionalized care, one of the things we would expect is that there's going to be supervising people in their life who can carry out a home program with them. So a therapist working with a psych patient might set up a program that can be then carried out by a non-licensed, non-skilled person pretty quickly. So again, that's going to impact your duration. And one of the areas that we're seeing denied right now is long duration psychiatric patients that have just a little bit of weakness, just a little bit of flexibility issues, etc. And what's the topic? Okay. The topic is the fact that 97110 therapeutic exercise is being denied heavily right now, and I'm writing lots of denials for it. And so anyway, I'm talking about that. So thanks for jumping in. For some reason, it's not showing me names or anything. But anyway, appreciate watching. And this will be posted, of course, to YouTube afterwards. My first opportunity in doing this. So anyway, with psych patients, you got to get to the nitty gritty. You're going to need to look for opportunities to discharge that patient fairly quickly because long length of stays and high intensity therapy are under fire. And that's the other thing that we're seeing denials related to Therex is when you have patients that are getting a lot of therapy and they've got Therex and they've got things like psych diagnoses or diagnoses that don't necessarily lead to the problem with strengthening, flexibility, range of motion, or endurance, those four criteria for Therex. We are seeing high utilization patients being denied. So what's the bottom line of all this? If you want to prevent denials when you're utilizing therapeutic exercise, number one, diagnoses are your number one helper there. Do the diagnoses on your claim support that there will be a strength, flexibility, range of motion, or endurance issue? So that's your first line of defense. Number two is that your assessments need to be nitpicky for looking for problems in those areas. Number three, if you've got psych patients, you should be looking at limited frequency, limited intensity, limited duration, and looking to, as quickly as you can safely and effectively do it, discharge the patient to a home exercise program, either with a loved one, CNA, whoever might be carrying out things after that. So somebody asked, what's my specialty? I'm a physical therapist, and my specialty for the last 9 years has been in Medicare compliance and clinical education of PTs, OTs, and speech therapists, not just in the area of getting claims paid, but also in just clinical excellence, mainly working with the geriatric population. But now for the last 2 years, my job has been primarily focused on making sure that Medicare claims get paid. And so some of that involves education. Some of that involves doing appeals management, which I talked about early in the video, and then doing education to therapists on how to document skill. And if you are interested in following me at all for some training in that area, I speak for an organization called Summit Professional Education, and I teach a course called Documentation Boot Camp. It's available live in the United States, and also it's pre-recorded, and so you can buy that and watch it online and at your own time and pacing. I also teach for Summit an ethics course. It's just a 1-hour credit course that's available for PTs only. And then for a company called Allied Health Education, I have 3 courses that I'm teaching, both live and also pre-recorded. The first 2 are pre-recorded already, and that is Documentation Essentials, which is a 2-hour webinar, not as in-depth as my documentation bootcamp, but not bad. And it goes over some good stuff that helps a lot. And then Neuromuscular Reeducation, which I cover basically all the essentials that will help you get paid for neuromuscular reed. And I have a new course coming out very shortly, and that's on therapeutic exercise. And so that is just going to be live presented in the next couple of months, and then will be pre-recorded for watching online. And all of those courses I just mentioned are 2 credit hours. I missed the last question. Let me see if I can get this to pull it back up. Let me see what your name means. Sorry, it's blocking part of your question. All right, guys, we're going to try a different view. Okay, never mind. I want me to rotate my device, so that's not going to work. So anyway, sorry about that. That's the problem with technology over in Eastern Europe, is that sometimes we get interruptions in service. So anyway, what does my name mean? The Rehab Documentation Guru. I was just about to explain that that's a little bit tongue-in-cheek, meaning